Our learning objectives are to know the sonographic anatomy of the KUB ultrasound, indications of the KUB ultrasound, common variants of anatomy of the kidney, ureter, and bladder, common anomalies of the KUB system, major pathologies, and identification on KUB ultrasound. Each kidney is 11 centimeters long, 2.5 centimeter thick, 5 centimeter long. It weighs 120 to 170 grams in weight. Right kidney is slightly smaller than left. The renal size decreases with the age, and the renal size corresponds to the height of the person. Left kidney is 1 to 2 centimeters higher because of liver on the right side. The kidneys move with the respiration. On sonographic appearance of the kidney, the renal parenchyma is composed of renal cortex and medullary pyramids, these hypoechoic areas. These would make up the renal parenchyma. Renal sinus is this echogenic part which contains renal arteries, veins, and renal pelvis. It is echogenic because of the fat. Urinary bladder, when full, is rectangular in shape. Its wall thickness is 1 to 3 mm. When full, it should be less than 3 mm, and when collapsed, when empty, it should be less than 5 mm. The average volume of urinary bladder is 300 to 400 ml, and post-fired urine should be less than 50 ml. If it is more than 200 ml, then that indicates urinary retention. So the common indications of the KUB ultrasound are flank pain, the patients which commonly come to you, low back pain, pelvic pain, groin pain, dysuria, hematuria, renal stones, renal obstruction, chronic kidney disease, and renal mass. So a common anomaly that you see on ultrasound is junctional defect. Junctional defect is hyperechoic band of tissue that you see interiorly and superiorly within the kidney. This defect occurs at the site of fusion of the parenchymal masses during the embryological period, and it should not be confused with scarring or with angiomyolipoma. Column of Burton's extend between the renal pyramids. Sometimes they can hypertrophy because of unresolved polar parenchyma of one or both of the subkidneys that fuse to form the normal kidney. It should be less than 3 mm and should not be mistaken for a mass. Its vascularity is same as that of the rest of the kidney. Another variation that you see is persistent lobation. It is infolding of the cortex without loss of the parenchyma. The persistent lobation will be seen up to 4 or 5 years of age, but sometimes it is seen in adults as well. So do not mistake it for scarring. Compensatory hypertrophy of the kidney occurs when there is contralateral nephrectomy, renal agenesis, renal hypoplasia, renal atrophy, and renal dysplasia. The nephrons enlarge and take up the function of the opposite kidney and compensate for the function of the opposite kidney. The kidney would be enlarged, and on the opposite side, you would not see the kidney. The kidney, pelvic kidney, this is another anomaly that you may see in your practice. The ascent of the kidney is arrested in the pelvis, and the kidney would be small, it would be malrotated, and there would be decreased function of the kidney. Sometimes the kidney may ascend high up. It may ascend into the thorax through the foramen of Bogdalek. Usually thoracic kidney is of not much of significance. Horseshoe kidney is another anomaly that you may see. In this, the lower poles of the kidney fuse through isthmus. The isthmus may be composed of the renal parenchyma or may be composed of fibrous tissue. The kidney is lower in position as it is halted by the inferior mesenteric artery, and the kidney, there is rotation of the renal pelvis, which can result in pelvis ureteric junction obstruction. When you scan the kidney, the lower pole will extend medially and will continue with the lower pole of the other side. So the lower pole would not end, and if you continue medially, it would be joining the other pole. This kidney is predisposed to infection as well as to the stone formation. Duplex collecting system is simply a duplication of the kidney. It can be complete or incomplete. In incomplete duplication, each moiety has a ureter which enters separately into the bladder. The upper moiety is often complicated by obstruction due to ureterocele, and the lower moiety is complicated by reflux. In incomplete duplicating system, the two ureters unite and then they enter normally into the bladder. So what you see on the ultrasound, you would see that there is a break in this renal sinus parenchyma. Here you see there is break and the two moieties are separated by normal renal parenchyma. Here we see an example of duplex kidney where the upper pole moiety is normal and the lower pole moiety is complicated by reflux. In pelvic-ureteric junction obstruction, there is weakness of the muscle at the site of pelvic-ureteric junction. There could be a vessel crossing the pelvic-ureteric junction. There could be scar at the pelvic-ureteric junction. It would result in ballooning of the renal pelvis. With passage of time, the renal calyces would dilate and the renal cortex with time would atrophy and the renal function would decrease. Another pathology that we commonly see is renal cyst. The renal cyst, the diagnostic criteria is that its walls are barely perceptible. It has, there are no debris in it, and it shows posterior acoustic enhancement. On the other hand, the complicated cyst contains internal echoes. It contains septations, calcification, its walls are thick, and it may show mural nodularity. The internal echoes may be due to hemorrhage or due to infection. If the septa are thin or barely perceptible, it is usually benign. Thin wall or septal calcification are less concerning, whereas thick, irregular, amorphous calcifications are worrisome. Solid nodule within a cyst is worrisome for malignancy. Here you see a simple looking cyst but has got a mural nodule, and on color Doppler it shows vascularity and proved to be a renal cell carcinoma on biopsy. So always see for whether the cyst is simple or it is complex, and especially see for the wall thickness, for thick septations and mural nodularity in your ultrasound. Another pathology that you see is autosomal dominant kidney. In that the kidney would be enlarged and there would be cysts of variable sizes in the renal cortex as well as renal medulla. Cysts of variable sizes in the renal cortex and renal medulla. And eventually the kidney would be replaced by cysts. The presentation is with loin pain, with loin mass, with hypertension, and with decreased renal function. And there would be, most of the cases would have family history, but some cases are sporadic. The most common indication for ultrasound that you are doing is hydronephrosis. In hydronephrosis, there is dilatation of the renal pelvis as well as the callaceous system. Renal pelvis as well as callaceous system. Here we see these dilated cystic structure, but these did not communicate with the renal pelvis. So these were parapelvic cysts which simulate hydronephrosis. So always see that whether the calyces are communicating with the renal pelvis or not. Otherwise, you may diagnose parapelvic cysts as hydronephrosis. The renal sinus cysts are of two types: parapelvic, which originate from the adjacent parenchyma and protrude into the renal sinus, and peripelvic cysts, which originate within the sinus itself and have a lymphatic origin. Here we see a peripelvic cyst simulating hydronephrosis, but if you scan through the kidney and see, it would not be communicating with the renal pelvis. Acute pyelonephritis is bacterial infection of the kidney. The patient presents with flank pain, fever. It could be due to ascending infection. It could be due to hematogenous spread of the infection. There would be enlargement of the kidney. There would be loss of corticomedullary differentiation. You may see an ill-defined mass like this, hyperechoic mass in the upper and mid pole of the kidney. And if the gas is within the parenchyma, it would be secondary to gas-forming bacteria. This is another example. The kidney is enlarged, the corticomedullary differentiation is lost, the parenchyma is hyperechoic. If the infection is untreated, it may lead to renal abscess. It would be round, thick-walled, hypoechoic mass with good through transmission. You may see internal debris and septation, and you may see gas. Here we see an example of a round hypoechoic lesion with debris layering in it. This is another example of a renal abscess containing internal debris. Pyelonephrosis is purulent material in the obstructing collecting system. Here we see dilatation of the pelvic callaceous system, and it contains internal debris, and there is layering of the debris. So that is very important to identify that, because if untreated, it can lead to bacteremia and can lead to septic shock. So its identification and its urgent drainage is absolutely essential. Renal tuberculosis can affect the kidneys. Tuberculosis can affect the kidneys, manifest 5 to 10 years after the pulmonary tuberculosis. Tuberculomas form, and tuberculomas may enlarge and cavitate and communicate with the collecting system. After rupture into the collecting system, the infection spreads to other part of the urinary tract. Early bladder manifestations include mucosal edema and ulceration. On ultrasound, you may see focal or diffuse wall thickening. Chronic changes that you would see on the ultrasound of renal tuberculosis include fibrotic strictures, cavitation, calcification, perinephric abscess, and fistulae. Here we see a case where you see clubbing of the upper and middle pole calyces. There is dilatation of the calyces, and it is associated with the calcification at the infundibulum, at the upper infundibulum of the kidney. Here we see another case where there is dilatation of the upper pole, and it contains a mass which is a fungal mass, hyperechoic lesion in the dilated calyx secondary to tuberculosis. Another indication is evaluation of the chronic kidney disease. In chronic kidney disease, there will be reduced cortical thickness of the kidney. The cortical thickness is often less than 6 mm. Normal is 15 to 20 mm, it would be less than 6 mm. The renal length would be reduced, and there would be increased cortical echogenicity, and the CM differentiation would be lost. Cystitis is infection of the bladder. Women at increased risk due to short urethra. In male, it could be due to bladder outlet obstruction, enlarged prostate, or prostatitis. In this case, we see there is wall thickening of the bladder. The wall thickness should measure less than 3 mm, and here it measures 7 mm. Renal calculi form due to dehydration, urinary stasis, hyperuricemia, hyperparathyroidism, hypercalciuria. In past 10 or 15 years, KUB ultrasound has taken up evaluation of the renal and ureteric calculi. However, ultrasound is still good in evaluation of stones greater than 5 mm. For stones less than 5 mm, the sensitivity is less. They appear as echogenic foci with sharp distal acoustic shadowing. On Doppler ultrasound, you would see twinkling artifacts. Here you see an echogenic lesion at the junction of lower and middle pole calyx, an echogenic lesion in the lower pole calyx with acoustic shedding, and on Doppler it showed twinkling artifacts. So it's always handy to have a Doppler in your machine that would help in evaluation of the renal stones. There are some mimics of the renal calculi, which is intrarenal gas due to infection, renal artery calcification in the old patients, and calcified slough papilla are the common ones. Uretary calculi, the most proximal and the most distal part, may be seen by ultrasound. The rest of the ureter is obscured by the ball gases. If the ureter is dilated, you may see the distal third of the ureter as a hypoechoic area entering into the bladder. Here we see a stone and the distal dilated ureter. Sometimes the distal ureter is not seen on transabdominal ultrasound. In that case, TVS and transperineal ultrasound can help. Then ureteral jets can help evaluate the site of obstruction. For that, you have to use Doppler and you have to image the bladder for some fairly long time, but if the up to 3 to 5 minutes. But if the patient is well hydrated, you may see the ureteral jets earlier. The patient with high-grade obstruction will have either completely absent jet or a continuous low jet on the symptomatic side. Here we see twinkling artifact due to a stone in the distal ureter and a low jet on the obstructed side. The ultrasound is optimal for the diagnosis of the renal mass. Renal cell carcinoma is 3% of all malignancy. Most of them are solid at ultrasound. They may be isoechoic, hypoechoic, or hyperechoic. Here we see a collage of renal cell carcinomas. It may be a cystic mass with thick septations. It may be an infiltrating lesion starting from the upper pole, invading the renal sinus. Enlargement of the kidney is seen. Here we see a mass of the low pole of the kidney, heterogeneous mass. It has obstructed the renal pelvis, resulting in dilatation of the upper pole calyx. Here we see a small hypoechoic mass at the upper pole of the kidney. Sometimes the renal cell carcinoma may be seen as a hyperechoic lesion, particularly in small renal cell carcinomas. Here it is confused with angiomyolipoma. Whenever you are in doubt, always do a CT scan. Do not label it as an angiomyolipoma. If you are in doubt, always get the CT scan done. Renal cell carcinoma may invade the renal vein and then extend into the IVC. And it is a tumor thrombus, not a bland thrombus. So it would show vascularity on the Doppler. When you put in the Doppler, it would show vascularity. Transitional cell carcinoma affects the renal pelvis and the calyx and the bladder and the ureters. It may be seen as a hypoechoic lesion infiltrating in the renal pelvis or in the calyxes. Here we see hypoechoic lesion which has resulted in loss of the renal sinus fat. There may be distortion and enlargement of the kidney with maintenance of reniform shape. So if a patient presents to you with hematuria and you see such appearances, you next go for CT scan. Transitional cell carcinoma is more common than transitional cell carcinoma of the kidney. It is 3 times more common in male. The patient would present with hematuria. Ultrasound is good for the diagnosis. Here we see a polypoidal lesion extending into the bladder lumen. Here you see another larger mass which is extending into the lumen as well as into the perinephric fat. The ultrasound is good for the diagnosis, but for staging you would need CT scan. So for staging, then you send the patient for CT scanning. The lymphoma involves the kidney. There is secondary involvement of the kidney through hematogenous spread. it may form a focal parenchymal mass, which would be hypoechoic and sometimes anechoic, just like a cyst. But there would be no through transmission. Here we see a hypoechoic lesion in the kidney. There could be diffuse infiltration of the kidney, and like in this case, the kidney is diffusely enlarged, it is echogenic, and the kidneys may be involved from the invasion from the retroperitoneal mass. There can be, after the mass involved the kidney, there can be perirenal involvement as well. Angiomyolipomas are benign tumors composed of fat, muscle, blood vessels. They may be in the parenchyma and may be exophytic. Here we see a well-defined hyperechoic lesion at the junction of the upper and middle pole. And if the fat content is high, it would be hyperechoic. If muscle and blood vessels are predominant, then it would be hypoechoic. It would be well-defined. When angiomyolipomas enlarge more than 4 centimeters, they have tendency to bleed. Small angiomyolipomas are without any consequence, but the larger lesions may bleed. Ultrasound of the prostate, transabdominal ultrasound of the prostate is used for the size assessment. It should not be more than 30 ml. Here you see a prostate myriad in AP transverse and longitudinal axis. But optimal evaluation of the prostate would need transrectal ultrasound. In transrectal ultrasound, you would see the zonal anatomy of the prostate. Here you see the transitional zone and the peripheral zone. The transitional zone enlarges in the benign prostatic hyperplasia, whereas malignancy is seen in the peripheral zone. Here you see an enlarged transitional zone in benign prostatic hypertrophy, and you would also evaluate the post-void of the post-void urine of the patient. Transrectal ultrasound showing a hypoechoic lesion in the periphery of the prostate that would indicate most likely a malignancy. Adrenals are less well seen. The right adrenal may be better seen than the left. The ultrasound has less sensitivity for evaluation of the left adrenal. They are V or Y-shaped hypoechoic bands. Here you see hypoechoic band lateral to the IVC between the liver and the kidney. You may evaluate it for the, you may see a mass in the kidney, mass in the adrenal, like in this case. The adenomas are mostly homogeneous, and if you see any heterogeneity, you have to resort for the CT. Here we see a cyst interposed between the upper pole of the kidney and between the liver. But for optimal evaluation of the adrenals, we would recommend CT and lab evaluation. So thank you very much. That was a quick tour of the ultrasound of the kidney, ureters, and bladder.